6.2 Adolescent Brain. The brain undergoes dramatic changes during adolescence. Although it does not get larger, it matures by becoming more interconnected and specialized. JID, 2015. The myelination and development of connections between neurons continues. This results in an increase in the white matter of the brain, and allows the adolescent to make significant improvements in their thinking and processing skills. Different brain areas become myelinated at different times. For example, the brain's language areas undergo myelination during the first 13 years. Completed insulation of the axons consolidates these language skills, but makes it more difficult to learn a second language. With greater myelination, however, comes diminished plasticity as a myelin coating inhibits the growth of new connections. Dobbs, 2012. Even as the connections between neurons are strengthened, synaptic pruning occurs more than during childhood as the brain adapts to changes in the environment. This synaptic pruning causes the gray matter of the brain, or the cortex, to become thinner but more efficient. Dobbs, 2012. The corpus callosum, which connects the two hemispheres, continues to thicken, allowing for stronger connections between brain areas. Additionally, the hippocampus becomes more strongly connected to the frontal lobes, allowing for greater integration of memory and experiences into our decision-making. Figure 6.6, the limbic system. The limbic system, which regulates emotion and reward, is linked to the hormonal changes that occur at puberty. The limbic system is also related to novelty seeking and a shift toward interacting with peers. In contrast, the prefrontal cortex, which is involved in the control of impulses, organization, planning, and making good decisions, does not fully develop until the mid-20s. According to JID, 2015, the significant aspect of the later developing prefrontal cortex and early development of the limbic system is the mismatch in timing between the two. The approximately 10 years that separates the development of these two brain areas can result in risky behavior, poor decision-making, and weak emotional control for the adolescent. When puberty begins earlier, this mismatch extends even further. Teens often take more risks than adults, and according to research it is because they weigh risks and rewards differently than adults do. Dobbs, 2012. For adolescents, the brain's sensitivity to the neurotransmitter dopamine peaks, and dopamine is involved in reward circuits, so the possible rewards outweighs the risks. Adolescents respond especially strongly to social rewards during activities, and they prefer the company of others their same age. In addition to dopamine, the adolescent brain is affected by oxytocin, which facilitates bonding and makes social connections more rewarding. With both dopamine and oxytocin engaged, it is no wonder that adolescents seek peers and excitement in their lives that could end up actually harming them. Because of all the changes that occur in the adolescent brain, the chances for abnormal development can occur, including mental illness. In fact, 50% of the mental illness occurs by the age 14 and 75% occurs by age 24, JID, 2015. Additionally, during this period of development, the adolescent brain is especially vulnerable to damage from drug exposure. For example, repeated exposure to marijuana can affect cellular activity in the endocannabinoid system. Consequently, adolescents are more sensitive to the effects of repeated marijuana exposure. Weir, 2015. However, researchers have also focused on the highly adaptive qualities of the adolescent brain, which allow the adolescent to move away from the family towards the outside world. Dobbs, 2012, JID, 2015. Novelty seeking and risk taking can generate positive outcomes, including meeting new people and seeking out new situations. Separating from the family and moving into new relationships and different experiences are actually quite adaptive for society. License. Lifespan Development, A Psychological Perspective. Copyright 2021 by Martha Lally and Suzanne Valentine French, is licensed under a Creative Commons Attribution Non-Commercial Share Alike 4.0 International License. 6.3 Adolescent Sleep. According to the National Sleep Foundation, NSF, 2016, adolescents need about 8 to 10 hours of sleep each night to function best. The most recent Sleep in America poll in 2006 indicated that adolescents between 6th and 12th grade were not getting the recommended amount of sleep. On average, adolescents only received 7.12 hours of sleep per night on school nights, with younger adolescents getting more than older ones, 8.4 hours for 6th graders and only 6.9 hours for those in 12th grade. For the older adolescents, only about 1 in 10, 9%, get an optimal amount of sleep, and they are more likely to experience negative consequences the following day. These include feeling too tired or sleepy, being cranky or irritable, falling asleep in school, having a depressed mood, and drinking caffeinated beverages, NSF, 2016. Additionally, they are at risk for substance abuse, car crashes, poor academic performance, obesity, and a weakened immune system, Weintraub, 2016. Figure 6.7, Adolescents often do not get enough sleep. Why don't adolescents get adequate sleep? In addition to known environmental and social factors, including work, homework, media, technology, and socializing, the adolescent brain is also a factor. As adolescents go through puberty, their circadian rhythms change and push back their sleep time until later in the evening, Weintraub, 2016. This biological change not only keeps adolescents awake at night, it makes it difficult for them to get up in the morning. When they are awake too early, their brains do not function optimally. Impairments are noted in attention, behavior, and academic achievement, while increases in tardiness and absenteeism are also demonstrated. To support adolescents' later sleeping schedule, the Centers for Disease Control and Prevention recommended that school not begin any earlier than 8:30 a.m. Unfortunately, over 80% of American schools begin their day earlier than 8:30 a.m. with an average start time of 8:03 a.m., Weintraub, 2016. Psychologists and other professionals have been advocating for later school times, and they have produced research demonstrating better student outcomes for later start times. More middle and high schools have changed their start times to better reflect the sleep research. However, the logistics of changing start times and bus schedules are proving too difficult for some schools, leaving many adolescents vulnerable to the negative consequences of sleep deprivation. License. Lifespan Development, a Psychological Perspective. Copyright 6.4, Adolescent Sexual Activity. By about age 10 or 11, most children experience increased sexual attraction to others that affects social life, both in school and out, McClintock and Hurd, 1996. By the end of high school, more than half of boys and girls report having experienced sexual intercourse at least once, though it is hard to be certain of the proportion because of the sensitivity and privacy of the information. Center for Disease Control, 2004, Rosenbaum, 2006. Adolescent pregnancy. Although adolescent pregnancy rates have declined since 1991, teenage birth rates in the United States are higher than most developed countries. Figure 6.8, Live births rates over the years by ethnicity. In 2014, females aged 15 to 19 years experienced a birth rate of 24.2 per 1,000 women. This is a drop of 9% from 2013. Birth rates fell 11% for those aged 15 to 17 years and 7% for 18 to 19-year-olds. It appears that adolescents seem to be less sexually active than in previous years, and those who are sexually active seem to be using birth control, CDC, 2016. Figure 6.8 shows the birth rates, live births, per 1,000 females aged 15 to 19 years for all races and Hispanic ethnicity in the United States, 1991, 2007, 2011, 2012, and 2013. Risk factors for adolescent pregnancy. Miller, Benson, and Galbraith, 2001, found that parents/child closeness, parental supervision, and parents' values against teen intercourse, or unprotected intercourse, decreased the risk of adolescent pregnancy. In contrast, residing in disorganized/dangerous neighborhoods, living in a lower SES family, living with a single parent, having older sexually active siblings or pregnant/parenting teenage sisters, early puberty, and being a victim of sexual abuse place adolescents at an increased risk of adolescent pregnancy. Consequences of adolescent pregnancy. After the child is born, life can be difficult for a teenage mother. Only 40% of teenagers who have children before age 18 graduate from high school. Without a high school degree, her job prospects are limited and economic independence is difficult. Teen mothers are more likely to live in poverty, and more than 75% of all unmarried teen mothers receive public assistance within 5 years of the birth of their first child. Approximately, 64% of children born to an unmarried teenage high school dropout live in poverty. Further, a child born to a teenage mother is 50% more likely to repeat a grade in school and is more likely to perform poorly on standardized tests and drop out before finishing high school. March of Dimes, 2012. Research analyzing the age that men father their first child and how far they complete their education have been summarized by the Pew Research Center, 2015, and reflect the research for females. Among dads ages 22 to 44, 70% of those with less than a high school diploma say they fathered their first child before the age of 25. In comparison, less than half, 45%, of fathers with some college experience became dads by that age. Additionally, becoming a young father occurs much less for those with a bachelor's degree or higher, as just 14% had their first child prior to age 25. Like men, women with more education are likely to be older when they become mothers. License. Lifespan Development, a Psychological Perspective. Copyright 2021 by 6.5. Eating disorders. Although eating disorders can occur in children and adults, they frequently appear during the teen years or young adulthood. National Institute of Mental Health, NIMH, 2016. Eating disorders affect both genders, although rates among women are 2.12 times greater than among men. Similar to women who have eating disorders, men also have a distorted sense of body image, including muscle dysmorphia or an extreme concern with becoming more muscular. The prevalence of eating disorders in the United States is similar among non-Hispanic whites, Hispanics, African Americans, and Asians, with the exception that anorexia nervosa is more common among non-Hispanic whites. Hudson, Hiraipai, Pope, and Kessler, 2007, Wade, Keskirainen, and Hudson, 2011. Figure 6.9, Eating disorders involve a distorted sense of body image. Risk factors for eating disorders. Because of the high mortality rate, researchers are looking into the etiology of the disorder and associated risk factors. Researchers are finding that eating disorders are caused by a complex interaction of genetic, biological, behavioral, psychological, and social factors. NIMH, 2016. Eating disorders appear to run in families, and researchers are working to identify DNA variations that are linked to the increased risk of developing eating disorders. Researchers have also found differences in patterns of brain activity in women with eating disorders in comparison with healthy women. The main criteria for the most common eating disorders, anorexia nervosa, bulimia nervosa, and binge eating disorder, are described in the Diagnostic and Statistical Manual of Mental Disorders 5th edition, DSM-5, American Psychiatric Association, 2013, and listed in Table 6.1. Table 6.1, DSM-5 Eating Disorder. Anorexia nervosa. 1. Restriction of energy intake, leading to a significantly low body weight. 2. Intense fear of gaining weight. 3. Disturbance in one's self-evaluation regarding body weight. Bulimia nervosa. 1. Recurrent episodes of binge eating. 2. Recurrent inappropriate compensatory behaviors to prevent weight gain, including purging, laxatives, fasting, or excessive exercise. 3. Self-evaluation is unduly affected by body shape and weight. Binge eating disorder. 1. Recurrent episodes of binge eating. 2. Marked distress regarding binge eating. 3. The binge eating is not associated with the recurrent use of inappropriate compensatory behavior. Health consequences of eating disorders. For those suffering from anorexia, health consequences include an abnormally slow heart rate and low blood pressure, which increases the risk for heart failure. Additionally, there is a reduction in bone density, osteoporosis, muscle loss and weakness, severe dehydration, fainting, fatigue, and overall weakness. Anorexia nervosa has the highest mortality rate of any psychiatric disorder. Arcelus, Mitchell, Wales, and Nielsen, 2011. Individuals with this disorder may die from complications associated with starvation, while others die of suicide. In women, suicide is much more common in those with anorexia than with most other mental disorders. The binge and purging cycle of bulimia can affect the digestive system and lead to electrolyte and chemical imbalances that can affect the heart and other major organs. Frequent vomiting can cause inflammation and possible rupture of the esophagus, as well as tooth decay and staining from stomach acids. Lastly, binge eating disorder results in similar health risks to obesity, including high blood pressure, high cholesterol levels, heart disease, type 2 diabetes, and gallbladder disease. National Eating Disorders Association, 2016. Eating disorders treatment. To treat eating disorders, adequate nutrition and stopping inappropriate behaviors, such as purging, are the foundations of treatment. Treatment plans are tailored to individual needs and include medical care, nutritional counseling, medications, such as antidepressants, and individual, group, and/or family psychotherapy. NIMH, 2016. For example, the Maudsley approach has parents of adolescents with anorexia nervosa be actively involved their child's treatment, such as assuming responsibility for feeding the child. To eliminate binge eating and purging behaviors, cognitive behavioral therapy, CBT, assists sufferers by identifying distorted thinking patterns and changing inaccurate beliefs. Figure 6.10, the Maudsley Family-Based Treatment. License. Lifespan Development, a Psychological Perspective. Copyright 2021 by Martha Lally and Suzanne Valentine French, is licensed under a Creative Commons Attribution Non-Commercial Share Alike 4.0 International License,